Assalamualaikum and good day to all. First and foremost, I would like to apologize for not being able to be physically present. And secondly, I would like to thank the organizing committee as well as APAGE and OGSM and ISMIVS for inviting me to give this talk this morning. So talk today is going to be about surgical management of endometriomas to optimize future fertility. I will probably not be concentrating much on the history, investigation, and as well how do you diagnose endometriomas, because I think everybody here is experts in it. But I think it's more about understanding how you're going to deal with endometrioma and ensuring that you will not compromise fertility treatment in order to ensure that patient objective in bearing children is fulfilled. All right. As you all know, endometriosis, 10% of women affected globally, and approximately 17 to 44 of them with endometriosis will have an associated endometriomas. These lesions are commonly referred to as chocolate cysts due to the thick dark brown appearance of the fluid contained within them. And as you know, that endometriosis they come with multifaceted and multifaces. They can come with pain, they can come with infertility, as well as they can come with progression of the disease. Now, or they can come with combination of all these factors. Now, today we'll be concentrating on endometriomas and how to approach them in relation to the fertility treatment. And we should also understand that endometriosis and fertility are very closely related. And in order to assess infertility in a woman, we should always remember that we should not exclude a possibility of combination factors. Therefore, the female or the male factor must also be excluded. Secondly, is that primary surgery is the most important approach and the most important treatment, not only to confirm, to stage the disease, or to assess the genital tract passage, uh, reducing pain and restoration of ovarian function. But data also shows that it improved fertility. In meta-analysis, it shows that it almost doubled the live birth or ongoing pregnancy rate in a patient who has gone primary surgery. Patient whom cannot conceive after the first surgery may indicate a more severe endometriosis. And then repeat surgery can treat pain, but does not improve fertility. It may damage more ovarian reserve and less ovum for assisted reproductive technique. Therefore, rather than going for secondary, as I mentioned just now, we should focus on fertility treatment as a method not only to achieve patient objective, but as well as to treat the disease. Now, therefore, let's look into endometrioma per se. Does it affect fertility or fertility treatment? Now, as you know that ovarian endometrioma will have some effect on the ovarian reserve. Let's look into the data. Now, endometrioma reduces AMH and decline over time, meaning that if you have endometrioma and you let it go for some time, you will have some problem in terms of the AMH value. And in a study of 40 patients, compared patients with endometrioma of more than 3 centimeters and 40 patients without endometriomas, they saw that the median AMH is low in endometrioma group, 2.83 versus 4.42 over 6 months. It declines further to 26% in the endometrioma group versus 7% in the non-endometrioma group. And even though the reduced MAH due to endometrioma, but there are also studies show that it does not affect the live birth rates after a successful IVF. However, reduce in AMH reduces number of follicle recruitment after exogenous FSH stimulation. So it reduces number of oocytes and embryo for further use in subsequent ART. Let's look into the surgery and ovarian reserve. Now, if you want to do an endometrial trauma surgery, you have to understand the impact of your surgery. Cystectomy reduces AMH but not antral follicle count. It is unclear the reduction of AMH is due to surgical trauma or ovarian tissue removal. Meta-analysis of 14 prospective studies which study pre and post cystectomy AMH and antral follicle count involving 650 women shows a reduction of AMH level at 44% at 6 weeks, in which they uh, face it as early, 35% further at 2 to 6 months, which they said as classified as intermediate, and 54% further at 9 to 18 months, which they classify as late. However, the antral follicle count is similar. Other studies also showed that if you do a bilateral cystectomy, it causes reduction of AMH more than a unilateral cystectomy. Now, a prospective study has shown as well that repeated surgery causes loss of more ovarian tissue and as well as antral follicle count. So it's just not only reduce the AMH, but also reduces the antral follicle count. Therefore, in endometrioma and infertility, endometrioma more than 3 centimeters reduces AMH, but of course, excision of endometriomas will also increase spontaneous pregnancy. So when we talk about excision of endometriomas, we have to talk about not only in relation to ART, but as well as if patient who has a normal functioning fallopian tube with endometrioma, so it increases the spontaneous pregnancy. But it has no impact on IVF or ICSI. So if you excise endometrioma, doesn't mean your ICSI or IVF success is going to be higher. So it is not indicated to increase IVF. It's not indicated as a reason for you to do surgery if there is an endometrioma, if it's just for the sole purpose of increasing your IVF and ICSI outcome. And of course, surgery, especially cystectomy, also reduces AMH, just like we had discussed before. So therefore, what are the indication for surgery actually? So I suppose if patient is asymptomatic and single, there's no issue of fertility, I think you should be more conservative in your approach. That will actually optimizes future fertility chances for her. And of course, unless the patient is symptomatic and you cannot exclude malignancy, therefore, I suppose that is the only way forward. But in taking into account approaches and the type of surgery that you should do to ensure that you do not compromise the ovarian reserve. And three, of course, primary surgery. So if they think that patient, uh, a couple who is married and presented endometriosis with endometrioma, primary surgery with a functioning fallopian tube will improve spontaneous pregnancy rate. And of course, if ART is concerned, you're talking about trying to reduce the size as well as the correct position to ensure that the possibility of follicle aspiration will not be difficult in cases where you need to do IVF or ICSI. So, what are the surgical? Is there any role of medical treatment before I go to the surgery? Of course, conception and pregnancy rate does not improve when endometrioma is treated with tenazole or GnRH analog. In Dynogest, it has also been studied. It reduces pelvic pain and reduces the size, but it does not actually relate in terms of fertility outcome. Although the cyst size reduces, but you do not have any improvement in terms of fertility rate. Therefore, you still need surgical intervention. So, what are the consideration and caution in terms of doing surgical therapy? Um, as we understand and what I've mentioned before with the data that we have now, we know that surgically removing ovarian tissue or endometrioma will diminish ovarian reserve. Now, especially we are talking about older age group. And secondly, we should avoid excessive excision of normal ovarian tissue because in those days, some cut or refashion normal tissues as a justification of a reconstruction of the ovary. It should not be practiced anymore. We should save as much as ovarian tissue as possible to ensure that the fertility chances is better for the couple. And of course, if there are small endometriomas, so less than 3 centimeters, you can just aspirate and just leave it behind rather than you traumatize or damage the ovarian tissues. And of course, we try to use suture for ovarian hemostasis and avoid diatomy as it will burn ovarian tissue, especially in widespread coagulation. And medical therapy post-surgery combination reduces pain but does not offer return or increase in fertility. Therefore, You do not need to combine medical endocrine treatment if ART is planned. You can actually proceed to ART. You can proceed with IUI or IVF once the patient has surgically recovered. Okay, so what are the endometrioma surgery that is available or approach that we can consider? So I do not have a specific solution on what type of surgical management or approach that you should practice, because I think it should be individualized to on a patient's basis. Probably at what age, a stage of subfertility, what whether it's a primary or it's a recurrent disease. So you have to individualize your approach. Okay. Now let's look into the. I've actually got this data and put it in a table so that I hope that it be much more concise and understandable. So when we talk about endometrioma, 25% of endometrioma probably recur. Okay, especially if it is more than 8 centimeters and above. All right. So, what type of surgery that you can actually offer, and what is the AMH effect on it, and what are the issues? Okay, if you look at that primary cystectomy, the issue is that it will reduce AMH level. However, the antral follicle is maintained. Method of cyst removal, stripping of the cyst, such as evisceration, is much more recommended instead of performing a circular excision around the cyst. Limits the number of normal ovarian follicle removed with the specimen. And of course, in secondary cystectomy, if in the case of recurrence disease, it will reduce the AMH further and also reduces the antral follicle. Therefore, it is not recommended if you plan for an ART. What about aspiration? So aspiration does not reduce the AMH level, but of course, the issue is that 80 to 100% we have recurrence rate about 6 months. And what about fenestration? Fenestration is removal part of the cyst wall and ablative coagulation or laser evaporation of the inner side of the wall. So the AMH will be reduced or equivocal. It is less effective than cystectomy, both in terms of improving fertility and reducing pain, but may have less impact on the ovarian reserve. What about sclerotherapy? Sclerotherapy using ethanol, tetracycline, alcohol, or methotrexate. So the AMH level is not reduced. Good in recurrent endometriomas. It will allow lucid retrieval. It causes fibrosis or sclerosing lining. Comparing sclerotherapy with surgical resection, have reported higher anti-Mullerian hormone level following sclerotherapy, but similar clinical pregnancy rate. So, and the recurrence rate is about 63% compared to cystectomy or no treatment at all. But basically, it is an alternative. You have a recurrent disease where you're trying to achieve uh, enough follicle for your ovarian reserve, especially for elderly women, to get it rather than going for a secondary cystectomy. Now, in terms of instrument for ovarian surgery, two different meta-analysis has reported hemostatic sealants and suture causes less reduction in AMH levels compared to bipolar electrosurgery, meaning that this should be the approach of choice now if you want to reduce the damage of the ovary. Try to stitch rather than you coagulate or uses uh, coagulative devices. Now, alternative to surgery, there were three small observational studies assessing the impact of Dinogest 2 milligram daily reported a significant reduction in terms of endometrioma volume, approximately 40% at about 6 months and as much as 76% at 12 months, in addition to reducing the pelvic pain scores as well. But it did not address the issue of infertility in medical therapy. So it's probably similar in terms of danazol and DNH-RH analog. If you are talking about future fertility and trying to um, use medical therapy as a approach, then probably it should not be considered solely, maybe in combination with some surgical procedures. Therefore, I would say that as a conclusion, I think that considering surgery for endometrioma to optimize future fertility must take into consideration few things. I think first thing is the marital status. If the patient is single, you may actually, and not much of symptom, you may actually resort to medical therapy as a first line rather than surgery, provided malignancy is not suspected and of course the symptoms are tolerable. And even if the surgery is indicated, you have to look into the fertility issue. If there is one, then I think it has to be addressed together and plan for the future and ensure that if there is a need, then you should refer to ART group as soon as possible. I think it should be planned together. Sometime most of our assisted reproductive group, reproductive technique group, probably will not have enough time to manage the complexity of the surgery in involving endometriosis. Therefore, probably we can actually manage it together with them. And of course, technical surgical approach must also take into consideration and minimize the ovarian reserve damage, especially in older age group. So therefore, you have to choose your approach wisely. Either you have to probably take an evisceration as a primary approach of technique of choice, as well as consider sclerotherapy if there is a recurrence and you are trying to achieve a good ovarian reserve in terms of providing you enough follicle for you to aspirate and so that you can actually do an IVF or ICSI. And in recurrent cases of subfertile patient, you should focus on ART apart from addressing fertility. Apart from addressing fertility, pregnancy is also a treatment modality, and followed by breastfeeding. So I suppose um, treating endometriomas as part of endometriosis disease is not easy. It's involve a lot of experience and of course wise decision making, and it should be planned together with reproductive group, assisted reproductive group, in order to achieve the best optimal outcome for patient after the surgical treatment. So I suppose with that, thank you very much. I hope my talk does help. We have not considered actually the technical issue in terms of addressing surgery when we talk about um, endometrioma. But I suppose with this talk, I hope that you will actually plan your surgical approach of choice. At the same time, you can also take into account of not using a lot of diatomy and using more of hemostatic suture rather than coagulating everything. That's and try to minimize the tissue damage by reducing the extraction of normal ovarian tissue when you are doing evisceration. With that, thank you very much. This is my reference. Assalamualaikum warahmatullah and good day to all again.